Hello and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Jaydira Del Rivero and Dr. Kimberly Perez, co-chairs on systemic therapy for tumor control in metastatic well-differentiated gastroenteropancreatic neuroendocrine tumors, ASCO Guideline. Thank you for being here, Dr. Del Rivero and Dr. Perez.
Thank you.
Thank you, Brittany.
And before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Del Rivero and Dr. Perez, who have joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. Then to start us off on the content of this guideline, Dr. Del Rivero, can you provide an overview of both the scope and the purpose of this guideline?
Thank you so much, Brittany, for the introduction. And I would like to thank ASCO as well for giving us the opportunity, me and Dr. Perez, to discuss briefly about the guidelines in gastroenteropancreatic neuroendocrine tumors. In terms of your question of providing an overview of the scope and purpose of this guideline, we wanted to make recommendations about the various systemic therapies and the management of advanced unresectable or metastatic gastroenteropancreatic neuroendocrine tumors from grade 1 to grade 3. I'm fortunate to be in the co-chair with Dr. Perez, but among the different experts and the panelists on this guidelines is that it's important to establish a guide on how to manage patients with gastroenteropancreatic neuroendocrine tumors. And one of the reasons is because there is really not sequencing of therapy. And there has been a lot of the discussions, even among the neuroendocrine tumor experts, but at the same time provide information and guide to oncologists in the community to understand more about the management of these neuroendocrine tumors, as well as provide a more standardized manner about how a neuroendocrine tumor expert sees or manage a patient with neuroendocrine tumor.
Great. Thank you for providing that overview. So you just mentioned that this guideline covers grade 1 to grade 3 gastroenteropancreatic neuroendocrine tumors. So Dr. Perez, what are the general recommendations that the panel made for grade 1 to grade 3 gastroenteropancreatic neuroendocrine tumors?
Thank you, Brittany. So I think the biggest take home for treatment for this group of tumors is based on the heterogeneity of the disease. So we can classify this very broad group of tumors into grade 1 to 3 based on histologic features. And we use that to guide treatment, but we also use the functionality of the tumors to direct treatment. And that can be assessed clinically, as well as by functional imaging or nuclear medicine-based imaging. And that's really how our intention in trying to provide recommendations for the treatment of these various tumor types. So we, as a group in our discussions, it really came down to approaching the patient situation, determining whether or not the patient had functional symptoms as a result of hormone excess, and then determining what their radiographic features were, specifically whether or not somatostatin receptor presence was noted, and then the grade of the tumor. And lastly, the bulk of disease and the rate of growth. And it's really those features that drive the different treatment options.
Excellent. Thank you for reviewing those general recommendations to identify those features that lead to specific treatment options. So Dr. Del Rivero, what systemic therapy options are recommended for first, second, and later line therapies for grade 1 to grade 3 gastroenteropancreatic neuroendocrine tumors?
As Dr. Perez mentioned earlier, neuroendocrine tumors are quite heterogeneous, and it's not like one size fits all in terms of how we manage patients with neuroendocrine tumors. As Dr. Perez mentioned too, in terms of how do we manage these neuroendocrine tumors, we need to consider the extension of the disease, whether is low burden tumors versus high burden tumor, what is the pace of growth, whether is stable or rapidly progressive, whether it's widely metastatic as well, or if it's only localized in one area, liver dominant disease. We also need to understand the primary site. And that's why these guidelines also we divide it in terms of how do we see in terms of first line and second line therapy between the pancreas and the small bowel neuroendocrine tumors. And as Dr. Perez said, the greater differentiation is also important. That's the reason why when discussing developing these guidelines, it was important also to differentiate between the grade 1, grade 2, as well as the grade 3, and also whether, as Dr. Perez mentions, whether they're functional tumors, meaning if they produce hormones or not, and the symptoms related to that. And I just would like to also mention that we're also currently working on symptom management of neuroendocrine tumors, taking in consideration of the hormone status of the tumors. And that's something that will follow up these guidelines as well. And as well as Dr. Perez mentioned, whether they express somatostatin receptors or not. So based on that, where the panelists, all the expert panelists as well, in developing these guidelines, we divide them into the grade 1 and grade 2 GI or gastrointestinal neuroendocrine tumors or pancreas neuroendocrine tumors. And that's based on the proliferation index as well. If there is the proliferation index of the Ki-67 is greater than 20%, we know that this is a grade 3 gastroenteropancreatic neuroendocrine tumors, which that in itself is a different category in terms of management. Now, in terms of the gastrointestinal grade 1, grade 2 neuroendocrine tumors as a first line of therapy, one of the things that we need to establish is whether the tumor expresses a somatostatin receptor or not. And that we confirm this via either a 68 gallium or 64 copper delta scan. And if they express the receptors, then our initial first line therapy of what is recommended in these guidelines is to start with somatostatin agonists, either octreotide or lanreotide. One thing to mention here is that either octreotide or lanreotide is equivalent in terms of efficacy. We don't have any head-to-head comparison to determine which one is maybe better. We think is equivalent, the two of them. And because of that, whichever is available is what we recommend. Now, if there's evidence of disease progression after the use of somatostatin agonists, then we need to determine whether they still express somatostatin receptors. And as a second line therapy, we can consider patients candidate for 177 lutetium dotatate or RRT with 177 lutetium dotatate. Usually what our recommendations are if the patient has a functional tumor, if it's producing hormones and symptoms related to the hormone excess, we still continue the somatostatin agonist. But if the tumor is a non-functional tumor after disease progression on somatostatin agonist, we don't necessarily need to continue the either lanreotide or the octreotide, long-acting octreotide. Now, sometimes some of the discussions that was done as well when developing these guidelines is a concern about hematologic toxicity. And if there is any concern of hematological toxicity, maybe the patient may not be a candidate for a 177 lutetium dotatate. And the situations where everolimus could be considered as a second or later line therapy in patients with G1, G2 gastrointestinal neuroendocrine tumors, if the patient is somatostatin receptor negative, so we can consider everolimus as well. So as you can see, in terms of the GI neuroendocrine tumors, we really need to take in consideration what we discussed earlier today and also discussed with Dr. Perez. Now, in terms of the grade 1 or grade 2 pancreas neuroendocrine tumor, similarly to what we discussed on the small bowel or GI neuroendocrine tumors, is first to determine whether there is somatostatin receptor positive and on scans, like we discussed, either 64 copper or 68 gallium dotatate scans. And based on that, usually the first line will be also consider somatostatin agonists, as discussed, either octreotide or lanreotide. Now, if there is disease progression on that, then we can consider other lines of therapies, such as peptide receptor radionucleic therapy or PRT with 177 lutetium dotatate, or chemotherapy with capecitabine and temozolomide, or everolimus or sunitinib. Now, one thing to keep in mind whenever we make these recommendations is for those pancreas neuroendocrine tumors that, besides being somatostatin receptor positive, are the ones that has a lower volume disease or without significant symptoms related to tumor burden. Now, we have a pancreas neuroendocrine tumors with higher volume disease and symptoms related to tumor burden, regardless of somatostatin receptor expression. Then usually what we can consider as what the panelist has considered as a first-line therapy is chemotherapy with capecitabine and temozolomide. And if there is any disease progression after that, then we also need to establish as well whether they still retain the somatostatin receptor avidity. If it's positive, then the other options to consider will be 177 lutetium dotatate, everolimus, or sunitinib. And those are the FDA-approved agents for the management of neuroendocrine tumors. And if there's somatostatin receptor negatives, will be everolimus or sunitinib. Now, in terms of the grade 3 gastroenteropancreatic neuroendocrine tumors when the K67 is greater than 20%. There are various options as well. And a lot of the treatments that has been recommended for grade 1 to grade 2 neuroendocrine tumors can also be recommended for a grade 3 neuroendocrine tumors. But that say, as we discussed earlier, we do also need to understand what is the growth of disease, or the aggressiveness of the disease, because depending on that, and also the symptoms related to that, as well as the tumor burden, but based on that, there may be other treatments available as well for the grade 3 neuroendocrine tumors, such as chemotherapy, various types of chemotherapies as discussed on the guidelines as well. There are ongoing clinical trials as well that help us understand and have more evidence-based therapy for the treatment decision of patients with gastroenteropancreatic neuroendocrine tumors.
Dr. Del Rivero, I appreciate you reviewing those recommendations and the nuance from the panel's discussion. Dr. Perez, is there anything you'd like to add about those recommendations?
Dr. Del Rivero covered everything that we intended to impart to the community about treatment of gastroenteropancreatic neuroendocrine tumors. I think the only highlight I would make, and was intentional on our part, was separating gastrointestinal and pancreatic neuroendocrine tumors, because there have been clinical trials demonstrating the different efficacy of treatments based on the primary site of disease.
Absolutely. That makes a lot of sense. So then, Dr. Perez, in your view, what is the importance of this guideline, and how does it both impact clinicians and patients with gastroenteropancreatic neuroendocrine tumors?
I think the importance of the guidelines, I found, was the common theme in our discussions with the other panelists on the group, was because of the rarity of the disease and the clinical trials that we are drawing our experience from. There's a lot of different ways to interpret the data that's available. And we all spent a lot of time discussing how we've interpreted the data and how we implement it in our practice, and how it's influenced the development of current clinical trials and the ideas supporting future clinical trials. And so I think that this was just, our intention was to provide community oncologists or general oncologists who don't see patients with this disease very often kind of algorithm or review of what is available and how you can try to put your patients into the algorithm in a way that will result in best results or best outcomes.
Absolutely. We hope this is a resource for community oncologists to help improve outcomes for their patients. And then you also just mentioned future clinical trials. So I'll turn back to Dr. Del Rivero, but what are the outstanding questions regarding systemic therapy for metastatic, well-differentiated gastroenteropancreatic neuroendocrine tumors?
Great. Thank you for that question. I would like to mention that the development of these guidelines, there was a few discussions about when to implement observation, because we know that patients with the neuroendocrine tumors, in terms of the biology, they may be very slow growing tumors. And one of the discussions were, when is observation recommended? And usually what the discussion was, and based on the consensus from all the panelists, is that observation could be considered in patients with low volume or very slow growing disease in the absence of any symptoms, meaning from either tumor burden or functional tumors. I think that could still be considered in a subset of patients. It's not necessarily for everyone. I think we agree that a lot of the patients with neuroendocrine tumors, when they present to us, already had metastatic disease, and that's when they're sick. The recommendations of a medical oncologist to determine what is the next line of therapy. One of the other discussions I would like to mention was about the deficiency of MGMT, and that was based on the data report by Dr. Pamela Kunz, and that was also presented at the ASCO meeting and recently published as well in the Journal of Clinical Oncology of the validity of MGMT deficiency in patients with pancreas neuroendocrine tumors, and that how that correlates with response. That said, I think the consensus was that is not really, even though we can consider that as a predictive biomarker, it's still not something that is a prime time to use, but that's something that it was recommended, that was discussed during the discussion of the development of these consensus statements. And Dr. Perez, I would like to also know the thoughts of Dr. Perez and what other important aspects were discussed during the development of the guidelines. But that said, I think a lot of the questions will be answered in ongoing clinical trials as well for metastatic neuroendocrine tumors. I think we're in a very exciting time where we have now seen a lot of more clinical trials for neuroendocrine tumors and a lot of treatment options than what it was more than 10 years ago. I think one of the questions is about sequencing too, and that's something that there is insufficient evidence in terms of what to recommend particular sequence of therapy. But that said, there has been ongoing studies presented at the ESMO meeting as well, and that in terms of some of the trial results and patients with gastroenteropancreatic well differentiated neuroendocrine tumors. But that said, still that's an ongoing question too. And ongoing trials is also currently active for not only for pancreas neuroendocrine tumors, but as well for gastric pancreatic and lung neuroendocrine tumors. And that's an exciting time also to learn more about the studies and looking forward to also learn about the results of the studies. And Dr. Perez, what are your thoughts?
I agree with all your sentiments. I think some additional topics of discussion that came up was in regards to how do you define burden of disease? So we use that as one of our characteristics for determining what treatment option we want to consider. And we really found that the data really only addressed this when trialists were looking at liver burden of disease. And so I think that is something as a scientific or clinical community, we need to maybe define a bit better in our future clinical trial efforts. I think the second is this question of Ki-67 and rate of growth. In Jennifer Ead's study looking at CAPE-TEM versus platinum and etoposide, and in the grade 3 group, the delineation made was a Ki-67 of around 55%. As her trial and other trials looking at the therapeutic options in this grade 3 category mature, we'll be able to better characterize that. And I think it will be important to provide guidance to patients and to providers. How do we really define that Ki-67 that requires the certain type of treatment? And then I think the last question I recall was in regards to using, somatostatin receptor-based therapy when you don't yet have somatostatin-based imaging, or when you have somewhat of a mixed uptake in somatostatin imaging. And I think that too, as the new radiopharmaceuticals are developed and the technology improves, I think this question will be answered.
Definitely. Those are important questions to determine therapeutic options for patients, and we'll look forward to those future developments ahead. So I want to thank you both so much for your work to develop this guideline and these recommendations. And I want to thank you so much for joining me here on the podcast today, Dr. Perez and Dr. Del Rivero.
Thank you, Brittany.
Thank you so much for having us.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/gastrointestinal-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.